Hello everybody, welcome to Palliative Care and Hospice. Now, it's pretty common that people get a palliative care track and hospice confused because they have a lot of similarities to them. They both focus on pain management and symptom relief, and they are both a multidisciplinary team-focused approach. There is no hospice guy that shows up to take care of somebody. But there are differences. For instance, when palliative care can happen at any stage. Now, it's specifically, I should say, the palliative care track, the palliative care treatment track, which is more focused, and that's what we're talking about here, which is more focused on symptom and pain reduction. You can start that at any stage of an illness. Remember, palliative care itself is just taking care of making someone feel better. Taking a Tylenol is palliative care. Kissing your kid's boo-boos, palliative care. Anything like that, anything that makes someone feel better is palliative care. Hospice care is specifically for people who have gotten a terminal diagnosis. And remember, that is that a doctor has said that a patient will die within 6 months without further treatment. So also the where is different. Palliative care is commonly done in a facility with the in-house care team because remember, we're still treating the illness, we're just making a bigger focus on comfort care. Hospice is commonly done from home, whatever home is for that person, whether it is their house or if they live in a facility, it's done from there. What is the scope in palliative care is predominantly patient-driven. That's their big focus. They seek to control symptoms and discomfort, and that means physical discomfort, mental discomfort, psychological, spiritual. That's all available in the palliative care track. The goal is to allow the patient to live the best life possible. Palliative is for patients who want or need relief at any stage of a disease. It doesn't even have to, I make that sound like I'm blowing it off. It doesn't have to be a terminal disease. It can just be an unpleasant one. There is no expectation within a palliative care track that any kind of life-prolonging therapies will be avoided. So what's your role in this? The major role for you is to continue to provide MNT and maintain their current level of nutritional health and functionality. But the secondary objective is to help the resident feel comfortable. And remember, we're trying to be as relaxed about this as we can be. So someone on a palliative care track, this is not the time to clamp down on sodium intake or something like that. If they want to be strict about it, and this is their call. If they want to be strict about it, we can be, right? We could still do finger sticks. We can keep them on a consistent carbohydrate diet. Some people don't care. And if they don't, it's not worth pushing the issue because this is about comfort care. Hospice is the scope is the patient and the family. It's the whole group. Their approach is pain management and symptom control. And again, same kind of thing. Not just physical pain, psychological distress too. They also educate the patient and family on what to expect. For the patient, it's what symptoms can you expect? What does the timeline look like most likely? For the family, it's telling them that also, but there's also people on the team that can help with financial matters, with legal concerns, and getting everything prepared so that when the patient expires, they're ready and they know what they need to do. Hospice is a complete focus on comfort. There is no aggressive disease treatment whatsoever. It is also focused on getting the most, letting them live their best life and trying to maximize the time they have left. All labs and therapies are stopped, and to a point at least. Labs are generally stopped. Sometimes therapy still happens because the patient wants to, and to keep them as active as possible. Now, one thing that is misunderstood often in hospice is that this doesn't mean no care. If the patient falls and breaks their arm, the hospice team's not going to be like, "Ooh, that looks painful. Too bad about that." That will be treated. They'll get antibiotics for an infection. Any kind of acute injury or disease will be treated. All that's not being treated is the terminal illness. And they also won't, but saying that, they'll do acute treatments, they won't do long-term life-prolonging treatments. So, for example, they won't do enteral feeding. If you want enteral feeding, you're going to have to leave the hospice program. They're not going to support that. Some therapies that are life-prolonging or could be considered life-prolonging, they will do. Those are continued for comfort measures. Those are things like, an example here is a handheld nebulizer and maybe oxygen for someone with COPD. Because if you've ever been in a situation where you haven't been able to breathe, that's scary and painful, and we want to avoid those. So giving them regular bronchodilating treatment is beneficial for them. So again, what's your role in this? Your role is the same as everyone's role, really, which is to maximize their care, their comfort, not their care, to maximize their comfort and make their last days as comfortable as possible. There are no dietary restrictions for someone on hospice. What's the point? What are we trying to do now? It's also important to remember that each person's individual, and this is geared toward the individual. So talk to them. What do they want? What do they consider a good life to be? What's worth living for? And try to work toward that as much as you can. Most disease states that will lead to someone being in hospice will eventually cause some symptoms. And we want to control for symptoms we can as much as possible. Things like nausea or vomiting, constipation, diarrhea, cramps, xerostomia, which is the inability to produce saliva. Those are common in things like cancer and AIDS. And we want to control for that as best as possible. There are expectations in this, given that this is a program for people with terminal illness. It's anticipated, your goal is to keep weight on them as long as possible, because more weight, remember, at least more lean body mass, means better outcomes. I mean, the outcome is understood here, but better quality of life, I guess I should say. But it is expected that at some point the patient's going to have a drop-off in their PO intake and an eventual weight decline. That's just a given. There are some interventions you can do. You could do nutritional supplements if they want them, if they even care. That's actually the first thing when I'm talking to a hospice patient and they've lost weight. I'm like, does this bother you? Are you concerned? If they're not concerned and we know what's going on, I generally don't do anything. If they are concerned, then we'll try some nutritional interventions. So nutritional supplements. Also, many people that are in hospice are on antidepressants and or anti-anxiety medications. And I'm sure you can understand why. So sometimes if they are concerned about their weight loss, but they've also lost the interest, the desire to eat, sometimes they'll add Remeron to their treatment regimen. Because remember, Remeron is an antidepressant that has the side effect of stimulating appetite. So again, if they are concerned and bothered, that might be something to suggest. And final thoughts. If you remember the video that Claire had, I feel like dietitians, if we do this well, have an ability in long-term care to develop a very good relationship with patients. I try very much to be the friendly person that they look forward to talking to, and not the mean nutrition Nazi that sometimes people think we are. It's important to remember, from what Claire said, people don't know how to talk to somebody with a terminal illness. And often they are scared and lonely. They don't have anybody to talk to. I try to use my relationship with them to give them some emotional support. Sit down and listen to them if you can. Talk to them, and talk to them like a normal person. I remember that distinctly, that one person actually mentioned that he appreciated that I talked to him, just regular conversations. Things that seem kind of stupid and petty, talk about sports, talk about the weather, whatever. Things that seem petty when you have a little bit of time left, maybe to us. We were thinking, if I was only had 3 months left, I wouldn't want to do that. But they lose that human connection, and that's something that everybody needs to be healthy. So be their friend. Be there for them as much as you can. Guys, that is hospice and palliative care, and I will catch you when we talk about end-of-life processes. Have a good one. Bye.